Welcome, learners, to another deep dive. Today we're tackling something really foundational for any nursing student and absolutely critical in practice.
You got it.
Understanding and managing cardiac dysrhythmias. I mean, this is where your knowledge really, truly translates to saving lives.
Absolutely. It's core nursing knowledge.
We've pulled our main stuff today from Lewis's Medical Surgical Nursing, the 12th edition. And our mission, well, it's to take this dense, vital information and distill it down, make it clear, actionable, give you that shortcut to confidence in recognizing and responding to these abnormal heart rhythms. Thinking like a nurse who's, ready for anything, and CLES included.
That's right. Because knowing your heart rhythms, it isn't just about passing an exam. It's about being able to rapidly assess your patient, make sure they're perfusing okay, and making those life-saving calls in real time.
Okay.
So we'll walk you through the heart's electrical system, how to actually read those squiggly lines on the ECG, and then really unpack the common dysrhythmias, what they look like, what they mean, and what you do about them.
Including the devices, right? Pacemakers, ICDs.
Yeah, absolutely. The nursing management, the patient teaching, all of it.
Okay, then. Let's unpack this chapter. Time to dive into the pretty fascinating world of cardiac electricity.
Let's do it.
The heart's electrical symphony. The basics.
Right. So to figure out what goes wrong, we kind of need to know what right looks like first. The heart's this amazing pump, right? And its rhythm, it's all orchestrated by a really precise electrical system, like a dance.
It really is. A beautifully choreographed dance, actually. And fundamentally, the heart cells themselves, they have four key properties.
Okay.
There's automaticity. It's their ability to just start an impulse on their own. Then excitability, how they respond to that stimulus. Conductivity, how they pass that impulse along. And finally, contractility. That's the muscle squeeze, the mechanical response.
Automaticity, excitability, conductivity, contractility. Got it.
Exactly. And the whole show normally kicks off at the SA node. It sits up there, the upper right atrium. That's your heart's natural pacemaker. Typically fires about 60 to 100 times a minute.
The boss?
The boss, yeah. So that impulse spreads through the atria, makes them contract, then it heads down to the AV node, through the bundle of Pis, splits into the bundle branches, and then zooms into the Purkinje fibers way down in the ventricles. And that triggers the big squeeze of ventricular contraction.
So a really clear, organized pathway. Boom, boom, boom. But what about, outside stuff, things that can mess with this harmony? The body isn't just working in a vacuum.
No, definitely not. That's where the autonomic nervous system comes in. Think of it like a dimmer switch for your heart rate and how fast the signals travel.
Oh.
You've got the vagus nerve that's parasympathetic. It slows things down, slows the SA node, slows the AV node conduction, lowers the heart rate.
Rest and digest.
Right. And then the sympathetic nerves, they're the accelerator. They boost SA node firing, speed up AV conduction, increase contractility, basically ramp up the heart rate. These influences can really, really change the rhythm and the patient's whole picture.
Decoding the ECG, your nursing superpower.
Okay, here's where it gets super critical for nursing students. The electrocardiogram. The ECG, it's not just squiggles on paper, right? It's like this immediate window into what the heart's electricity is doing. This is your nursing superpower, really, learning to read this language.
Absolutely. An ECG is just a graphic tracing of those electrical impulses. It shows us depolarization. That's the electrical activation making the muscle contract, and repolarization, the resting phase, getting ready for the next beat.
And this involves ions moving around.
Exactly. Sodium, potassium, moving across the cell membranes, that's what creates the electrical charges we can actually measure on the skin.
So how do we read it? As nurses, you see that strip printing out maybe in an emergency. What are we actually looking for?
Well, we use that special ECG paper with the grid for time and voltage. For a quick heart rate, if the rhythm's regular, just count the QRS complexes in a 6-second strip and multiply by 10.
Quick and dirty method.
Quick and dirty, yeah. Or, more precisely, you count the tiny squares between two R waves and divide 1,500 by that number. But the real key, having a system. A systematic approach you use every single time.
Right. Don't just jump to conclusions. Follow the steps.
Exactly.
And those different waves and intervals.
Yeah.
P wave, QRS. Each one tells a specific part of the story.
Precisely. Each piece paints part of the picture. Think of it like a mental checklist you run through. First, the P wave. That's atrial depolarization, the atria contracting.
Okay.
Then the PR interval. That measures the time from the start of the Q wave to the start of the QRS. Basically, getting the signal through the AV node if it's too long. might be an AV node conduction issue, a block.
Mm.
Then the big one, the QRS complex, that's ventricular depolarization, the ventricles contracting. If it's wide, like wider than normal, that could mean a problem down the bundle branches or the ventricles themselves.
This ventricular stuff, yeah.
Then the ST segment, this little line should be flat right at the baseline. Isoelectric, if it's elevated or depressed, that's a huge red flag. Could be ischemia, could be an MI, a heart attack.
Critical finding.
Very critical. Then the T wave, that shows the ventricles repolarizing, resetting. Changes there, like tall, peaked T waves. Could mean electrolyte problems like high potassium, hyperkalemia.
Okay.
And finally, the QT interval. That's the total time for the ventricles to depolarize and repolarize. Lots of things affect it. Heart rate, drugs, electrolytes. A prolonged QT can be dangerous.
So it's not just seeing the waves, it's their timing, their shape, how they all fit together. That really shows the complex thinking a nurse does layer by layer.
Exactly right. After you meticulously go through those steps, find the P wave, check the rates and rhythms, measure the intervals, look at the ST segment, then you ask the big questions. What is this rhythm? What does it mean for this specific patient right now? And what's the right treatment? That critical thinking pathway, that's fundamental for the NCLEX and definitely for real-world nursing.
Yeah, you can't just treat the monitor, you treat the patient.
Always.
But what if the strip looks messy? We've all seen those in clinicals, right?
Yeah.
Where it's hard to tell what's what.
Ah, yes. That's artifact. Think of it like static on a radio signal. It distorts the true picture of the heart's activity.
What causes it?
Oh, simple things sometimes. Loose electrode patches, maybe the gel is dried out, patient moving around, shivering, even electrical interference from other equipment in the room.
So what's the first nursing action?
Always check the patient first. Are they okay? Then check your equipment. Are the leads on securely? Good skin contact. Maybe change the patches. Address any patient movement if you can. Rule out artifact before you jump to diagnosing a weird rhythm.
Good point. Check the simple stuff first.
And remember, telemetry monitoring is huge in hospitals now. It lets us watch rhythms continuously from afar. And the systems are smart. They can often detect changes and store that data, which is incredibly helpful.
When the rhythm goes wrong, understanding dysrhythmias.
Okay, so when that electrical system does go off script, we get dysrhythmias. And that's often when a nurse's quick thinking is really, truly tested. What actually causes these disruptions, generally speaking?
Well, fundamentally, dysrhythmias come from two main problems. Either problems with making the impulse, like some irritable spot outside the SA node starts firing off an ectopic focus, or problems with conducting the impulse, maybe it gets blocked, or it takes a weird detour, like in reentry, and the triggers, lots of things. Heart conditions themselves, like after an MI, or heart failure. Electrolyte imbalances, high potassium is a big one, low calcium too, not enough oxygen, hypoxia, drug side effects, even just stress.
Lots of potential culprits.
Yeah.
Let's zero in on the most common ones, the ones you really need to know. We'll break down the ECG, what it means clinically, and crucially, the nursing actions.
Sounds good. Let's set the baseline. Normal sinus rhythm, NSR. That means the SA node is in charge, firing 60 to 100 times a minute. Everything looks normal. P wave, PR, QRS. That's our goal, usually.
Healthy rhythm.
Right. And then there's sinus arrhythmia. That's just an irregular NSR, often speeds up when you breathe in, slows when you breathe out. Super common, especially in healthy young people. Usually needs nothing.
Okay.
Now let's group the problematic ones. First, things starting up in the atria. Sinus bradycardia. Heart rate under 60. Now this can be normal, like in athletes or during sleep, but if the patient is symptomatic, dizzy, tired, low BP, that's a problem.
What do we do?
For symptomatic brady, your go-to drug is IV atropine. If that doesn't work, you might need temporary pacing, like transcutaneous pacing, or maybe a dopamine or epinephrine drip.
Okay, what about too fast?
That's sinus tachycardia, rate 101 up to maybe 180. Usually it's the heart responding to something, pain, fever, anxiety, low blood volume, maybe caffeine or certain drugs.
To find the cause.
Exactly. Your main job is to figure out why it's fast and treat that underlying cause. Sometimes vagal maneuvers help, or beta blockers, calcium channel blockers. But if the patient's unstable, low BP, chest pain paid, then it's rapid synchronized cardioversion time.
Got it. What about AFib? That one seems huge.
Atrial fibrillation, AFib. Yes, this one you absolutely must know inside and out. It's the most common dysrhythmia we see clinically that causes problems. You see this chaotic, irregular baseline. Those are fibrillatory F waves instead of P waves. The atria are just quivering, firing off maybe 350, 600 times a minute.
Wow.
And the ventricles respond irregularly, often rapidly. But the biggest takeaway, the number one nursing insight for AFib, stroke risk.
Why stroke?
Because atrias aren't contracting effectively, blood pools in there, especially in the little pouch called the left atrial appendage. Clots form, and if one breaks loose, stroke. AFib accounts for something like 1 in 7 strokes.
That's significant.
Hugely significant. So long-term anticoagulation warfarin, or the newer DOACs, is absolutely crucial for most AFib patients. Nursing priorities are rate control first, usually with beta blockers or calcium channel blockers, sometimes digoxin or amiodarone. And then rhythm control, maybe with electrical cardioversion, but you have to be very careful about clot risk, especially if they've been in AFib for more than 48 hours. Anticoagulate first.
Okay, rate control, rhythm control, and anticoagulation. Big priorities for AFib. What about atrial flutter?
Atrial flutter. That's the one with the classic sawtooth flutter waves, the F waves. The atrial rate is fast, maybe 200, 350. Like AFib, you lose that effective atrial contraction, the atrial kick, so cardiac output can drop. And also like AFib, high risk of thrombus formation.
So anticoagulation again?
Critical. Anticoagulation is key. Treatment focuses on slowing down that ventricular response again, calcium channel blockers, beta blockers, and sometimes electrical cardioversion is used to try and get them back into sinus rhythm or ablation.
Okay, so a common thread for both AFib and flutter is that hidden stroke risk, making anticoagulation a major nursing focus.
Absolutely.
But what if the problem isn't the atria quivering, but the signal getting stuck on its way down, the heart blocks?
Right, that takes us to the AV blocks. These affect the signal getting from the atria down to the ventricles through that AV node, first-degree AV block. This one's pretty simple. The PR interval is just longer than normal, consistently long, but every single P wave does get followed by a QRS. The signal gets through, just slowly.
So usually okay.
Usually asymptomatic, yeah. We just watch it, make sure it doesn't get worse. No specific treatment needed, typically.
Okay.
Second degree.
Now it gets trickier. Second-degree AV block, type I. That's the Wenkebach, remember the little rhyme. Longer, longer, longer drop. Now you have a Wenkebach.
Catchy.
It helps. The PR interval gets progressively longer with each beat until finally a P wave occurs and isn't followed by a QRS. A beat is dropped. Then the cycle repeats. It's often transient, maybe related to meds or ischemia if they're symptomatic, maybe atropine or temporary pacing.
And type 2, Mobitz 2. Second degree AV block, type 2, Mobitz 2. This one's more serious. Here, the PR interval is constant for the beats that do get through. But then suddenly, some P waves just don't get conducted at all. You just have P waves standing alone with no QRS after them. Maybe it's a 2.1 block or 3.1.
Why is it more serious?
Because it often happens lower down in the conduction system and has a higher risk of progressing suddenly to a complete heart block. This rhythm is usually an indication for a permanent pacemaker. You might need temporary pacing to bridge them.
Okay. And the worst block.
Third degree AV block, also called complete heart block. This is a critical situation. There's absolutely no communication between the atria and ventricles. The AV node is completely blocked.
So they beat independently.
Exactly.
Yeah.
AV dissociation. The atria fire away at their own rate, driven by the SA node maybe, and the ventricles. They rely on some escape pacemaker lower down, which is much slower, usually 20, 40 BPM. This drastically reduces cardiac output. Patients can have syncope, heart failure, shock.
What's the fix?
Immediate temporary pacing is needed, transcutaneous or transvenous, and then they need a permanent pacemaker implanted. Atropine won't work here because the block is below where atropine acts.
Critical rhythm needs pacing.
Definitely.
Okay. We've gone from the SA node through the atria, down the AV node with the blocks. Now, the really scary ones, right? When the ventricles themselves start acting up or taking over, this is where things can get truly life-threatening fast.
Yeah, these ventricular dysrhythmias are often the most urgent ones we deal with. Let's start with premature ventricular contractions, PVCs. These are early beats that originate from somewhere down in the ventricles. On the ECG, they look wide, bizarre, distorted compared to the normal QRS.
There's occasional extra beats.
Can be. They can be unifocal, all looking the same, coming from one spot, or multifocal, different shapes coming from different spots, which is usually more concerning. You might see patterns, like digeminy every other beat is a PVC, or trigeminy every third beat.
Are they always bad?
Not always. In a healthy heart, occasional PVCs might be benign, but in someone with heart disease, they can indicate ventricular irritability, maybe from low oxygen electrolyte problems or ischemia, and they can decrease cardiac output, especially if they're frequent. Always check an apical radial pulse. You might feel the normal beat, but not the weaker PVC beat, leading to a pulse deficit.
And that R on T thing.
Ah, yes, the R on T phenomena. That's when a PVC happens to fall right on the T wave of the preceding beat during that vulnerable repolarization period. That's particularly dangerous because it can trigger ventricular tachycardia, VT, or ventricular fibrillation, VF.
So what do we do about PVCs?
First, figure out why they're happening. Treat the cause, give oxygen if hypoxic, correct electrolytes like potassium or magnesium. Beta blockers might be used, or sometimes antidysrhythmics like amiodarone. And think about this scenario. You've got a 69-year-old guy, post-op from colon surgery, history of MIs. Suddenly his monitor alarms. It shows ventricular bigeminy. Rate is only 50. What's your very first action as the nurse?
Assess the patient.
Exactly. Before you even think about drugs or calling a rapid response, lay eyes on the patient, check their pulse, is it matching the monitor? Check their blood pressure, are they conscious? Any shortness of breath, chest pain, dizziness, signs of decreased perfusion. Your assessment guides everything that comes next. Okay, moving on. Ventricular tachycardia, VT. This is defined as 3 or more PVCs in a row. The ventricular rate is fast, usually 150-250 BPM. The QRS is wide. VT is always serious, potentially life-threatening, because that rapid rate doesn't allow the ventricles to fill properly, so cardiac output plummets.
And there are different kinds.
Yeah, it can be monomorphic, all the QRS complexes look the same, or polymorphic, they change shape. A specific type of polymorphic VT is Corsades de Pointe, which looks like the QRS is twisting around the baseline, often linked to a long QT interval.
Okay, VT is bad. What determines the treatment?
The big question is, does the patient have a pulse? Pulseless VT is a lethal emergency. No pulse, no cardiac output. You treat it exactly the same as ventricular fibrillation, immediate CPR and rapid defibrillation. Get that shock delivered ASAP.
Okay, pulseless VT equals CPR plus defib. What if they do have a pulse?
VT with a pulse. Now it depends if they're stable or unstable. If they're stable awake, talking, decent BP, you might have time for IV antidysrhythmic drugs like procainamide, amiodarone, maybe lidocaine. But if they're unstable, low BP, altered mental status, chest pain, signs of shock, then it's urgent synchronized cardioversion. Think about this one. 54-year-old teacher hits the ED. Short of breath, chest discomfort, feels like his heart is racing. He's sweaty, anxious, BP is low, 8654, heart rate is 230, ECG shows wild complex VT, his potassium is really low, 2.8. What's the priority here?
He's unstable, low BP, symptoms.
Right, he's unstable VT. So the most important immediate intervention is synchronized cardioversion. Shock him back into a better rhythm. Now, what if, while you're getting ready, he suddenly slumps over, unresponsive, no pulse?
Then he's in pulseless VT.
Exactly. And your immediate action shifts to
CPR. And get the defibrillator ready for an unsynchronized shock defibrillation.
Perfect. Recognizing that change in patient status and shifting gears immediately, that is absolutely critical nursing. Next up, ventricular fibrillation, VF. This is pure electrical chaos in the ventricles. The ECG looks like a totally disorganized, quivering line. No recognizable P waves, QRS, or T waves.
So no contraction.
No effective contraction at all. The ventricles are just fibrillating, quivering uselessly. There's no cardiac output. VF is a lethal emergency, just like pulseless VT.
Treatment.
Same drill. Immediate high-quality CPR, rapid defibrillation, the definitive treatment, and then advanced life support drugs like epinephrine, maybe amiodarone. Time is everything with VF. Every minute delay in defibrillation drastically reduces survival chances.
Got it. VF CPR plus defib immediately.
Immediately. Then there's a systole. That's the flat line. Total absence of any ventricular electrical activity. No contraction, no pulse.
Oh, lethal.
Yes, a systole is a lethal emergency, and unfortunately the prognosis is very poor. First thing though, always confirm it in at least 2 different ECG leads. Make sure it's not just fine VF that looks like a flat line, or maybe a lid fell off.
Rule out the simple stuff.
Right. Once confirmed, treatment is CPR, following ACLS protocols, epinephrine, intubation, trying to find and treat any reversible underlying causes, the H's and T's. But you do not defibrillate a systole. There's no electrical activity to reset.
No shock for a systole, CPR and meds.
Correct. And finally, one more tricky one. Pulseless electrical activity, PEA. This is when you see organized electrical activity on the monitor, maybe it looks like sinus rhythm or some kind of block, but when you check the patient, there's no pulse.
The electricity is there, but the pump isn't working.
Exactly. The heart's electrical system is firing, but it's not resulting in any mechanical contraction, no cardiac output. Prognosis is generally poor unless you can quickly figure out why and fix it. Think about the reversible causes, again, the H's and T's, like hypovolemia, hypoxia, thrombosis, tamponade, tension pneumothorax. Treatment starts with CPR and epinephrine while you urgently search for and treat that underlying cause.
Bringing it all together, interventions and devices.
Okay, so we've run through the rogues gallery of rhythms. We've identified it. Now what? especially when things go bad fast in an emergency. What's the core nursing management? This is where we really step in and make a difference.
Absolutely. In any dysrhythmia emergency, first principles apply. If the patient's unresponsive, think CAB, circulation first, start CPR, then airway, then breathing. If they're responsive, think ABC, airway, breathing, circulation.
Basic life support.
Foundational. Then get oxygen on them. Get a full set of vital signs. Check their O2 saturation. Get a 12-lead ECG if you can. Start continuous monitoring. Get IV access established, you'll need it. And draw baseline labs, especially electrolytes. Ongoing monitoring is absolutely key. You need to anticipate needing antidysrhythmic drugs or maybe escalating to advanced life support CPR, defibrillation, pacing.
Okay, let's talk about those big guns first. The electrical therapies. These are things nurses are often right there doing or assisting with in those urgent moments.
Yeah, these are critical life-saving skills. Let's break down the two main ones, defibrillation and cardioversion. Defibrillation. This is your go-to treatment for VF and pulseless VT. The goal is to deliver a big electrical shock that depolarizes essentially all the heart muscle cells at once. The hope is that the heart's natural pacemaker, the SA node, can then take over again with an organized rhythm.
Timing matters.
Hugely. It's most effective if done fast. Within the first couple of minutes of VF onset gives the best chance. We use defibrillator pads, and the energy level depends on the machine. Biphasic defibrillators are more common now, usually starting around 120-200 joules. The absolute critical safety point, the synchronizer switch, must be OFF. You want that shock delivered immediately, regardless of the heart's chaotic rhythm, and right after the shock. Resume CPR immediately. Don't pause to check rhythm right away.
Okay, defib for VF pulseless VT. Sync switch, OFF, shock, then CPR. Got it. What about cardioversion?
Synchronized cardioversion. This is different. This is for patients who have a tachyarrhythmia like VT with a pulse, or maybe unstable supraventricular tachycardias like AFib with a really rapid ventricular response, or SVT. The key here is the timing of the shock.
How so?
The machine looks for the R wave on the ECG, the peak of the QRS complex, and delivers the shock synchronized with that R wave. This is crucial to avoid delivering the shock during the T wave, that vulnerable period, which could actually cause VF.
Ah, so it avoids the R on T problem.
Exactly. So for cardioversion, the critical safety point is the synchronizer switch must be on-in. The machine needs to sense the R wave to deliver the shock safely. Energy levels are usually lower to start, maybe 50-100 joules for SVT or VT with a pulse. If it's not an emergency like an elective cardioversion for stable AFib, the patient is usually sedated beforehand because it can be uncomfortable.
Okay, cardioversion for unstable tachycardias with a pulse. Sync switch on in. Lower energy.
You got it. And the big safety alert. Shout it from the rooftops. OFF for defibrillation, on-in for cardioversion. Always. And never put those pads directly over an implanted pacemaker or ICD. And always, always shout all clear and make sure everyone is physically clear of the patient and the bed before you push that shock button. Non-negotiable safety for you and the team.
Absolutely critical points. What about the meds? We mentioned some, but what's the overview of pharmacological management?
Right, the antidysrhythmic drugs. They're generally grouped into classes based on how they affect the heart cell's electrical activity. Like class 2 are beta blockers, they slow the SA node, slow conduction. Class 3, like amiodarone, are potassium channel blockers that prolong repolarization. Class 4, calcium channel blockers. We also use others like adenosine, which is great for stopping SVT, and digoxin.
And the nursing care around these drugs?
It's intense. You need a thorough assessment, first history, allergies, baseline ECG, vitals. Continuous monitoring during AV administration is usually needed. Keep a close eye on the ECG for effects, both good and bad. Watch blood pressure, heart rate. Monitor labs, especially electrolytes, liver function, kidney function, as many of these drugs have side effects or specific monitoring needs. And patient teaching is huge, especially for oral meds they go home on. Take it as prescribed, watch for side effects, know when to call the doctor, often avoiding things like alcohol or caffeine that can trigger arrhythmias.
Okay. And for patients who need long-term protection or rhythm support, that brings us to the implantable devices, pacemakers and ICDs. Patient education must be huge here.
Oh, absolutely. These devices are incredible, but patients and families need to understand them. Let's start with the implantable cardioverter defibrillator, ICD. This is for patients at high risk of sudden cardiac death. Maybe they've already survived a cardiac arrest due to VT or VF, or they have conditions that put them at high risk.
What does it do?
It constantly monitors the heart rhythm. If it detects a life-threatening rhythm like VT or VF, it can deliver a low-energy shock internally to try and stop it. Much lower energy than an external defibrillator, usually 25 joules or less. Many modern ICDs can also act as pacemakers. They can pace if the heart goes too slow, anti-bradycardia pacing, or sometimes even deliver rapid pacing to try and stop VT before it needs a shock, anti-tachycardia pacing.
So what do you teach these patients?
A lot. Regular follow-up checks are vital to make sure the device is working and check the battery. Report any signs of infection at the incision site immediately. Keep the incision dry until healed. Avoid lifting the arm on the ICD side above the shoulder for a while, as prescribed. No direct blows to the device site. Avoid strong magnetic fields. MRIs are often contraindicated unless it's a specifically MRI conditional device and protocol. Airport security. Walk through normally. Don't linger, show your ID card. Cell phone's generally okay, but don't keep it in a pocket right over the device.
What if it fires?
If it delivers a shock. If it fires once and they feel okay, they should call their cardiologist's office. If it fires and they feel unwell, or if it fires multiple times, call 911 immediately. They absolutely need to wear a medical alert ID and carry their device identification card, and it's really important that family members or caregivers learn CPR.
Good points. What about pacemakers?
Pacemakers. These are electronic devices used when the heart's own conduction system is damaged and can't pace properly or fast enough. Like in symptomatic bradycardia or high-degree AV blocks, most pacemakers implanted today are demand pacemakers, meaning they sense the patient's own heart rhythm. If the heart beats on its own at an adequate rate, the pacemaker just listens. But if the heart rate drops below a certain preset level, the pacemaker kicks in and delivers an electrical impulse to make the heart beat. It only paces on demand.
And there are permanent and temporary ones.
Right. Permanent pacemakers are fully implanted under the skin, usually in the chest, with wires or leads going into the heart chambers, maybe the atrium, the ventricle, or both. Indications include those acquired AV blocks we talked about, symptomatic bradycardia not fixed by meds, sometimes after heart surgery.
Teaching for permanent pacemakers.
Similar to ICDs in many ways. Regular follow-up is crucial. Watch for infection. Incision care. Limit arm and shoulder activity on that side initially. Avoid direct blows. Avoid strong electromagnetic fields, though things like microwave ovens are generally safe now. Airport security, again, walk through, show the card. A key thing is teaching them how to take their own pulse daily and to report it to their doctor if it's consistently below the pacemaker's set rate. Wear medical alert ID, carry the card.
Okay. And temporary pacing.
Temporary pacemakers have the power source outside the body. Useful in emergencies or until a permanent one could be placed. 3 main types. Transvenous, a wire threaded through a vein into the heart connected to an external generator. Epicardial leads placed directly on the heart surface during cardiac surgery. Wires exit through the chest wall. And transcutaneous pacing, PCP, this is the non-invasive one. Large electrode pads placed on the chest and back, connected to an external pacer defibrillator.
That's the one we might use in an emergency.
Exactly. For severe symptomatic bradycardia or some heart blocks until something more stable is arranged. Important nursing point for TCP. It can be really uncomfortable for the patient because it stimulates skeletal muscles too. Explain that. Provide pain relief and sedation if ordered and appropriate.
Good tip. And what if a pacemaker isn't working right? Malfunction.
Yeah, nurses need to be able to spot pacemaker malfunction on the ECG. 3 main problems. Failure to sense. The pacemaker doesn't see the patient's own heartbeats when it should, so it might fire inappropriately, too close to the patient's own beat. You'll see pacer spikes where they shouldn't be. Failure to capture. The pacemaker fires, you see the spike on the ECG, but it doesn't result in a heartbeat. No P-wave or QRS complex follows the spike. The electrical stimulus wasn't strong enough to make the heart muscle respond. Failure to pace. The pacemaker just fails to fire at all when it's supposed to. The heart rate drops below the set rate, but you don't see any pacer spikes.
How do you fix those?
Troubleshooting involves checking all the connections first, especially for temporary pacemakers, checking the battery. Then adjusting the pacemaker settings, like increasing the output, milliamps, to fix failure to capture, or adjusting the sensitivity setting to fix failure to sense. This usually requires specific training or collaboration with cardiology or a pacemaker nurse.
Okay. One more intervention, ablation.
Right. Radiofrequency catheter ablation therapy. This is often a definitive fix, not just management. They thread catheters into the heart, map out the electrical system, find the specific spot causing the trouble, like an ectopic focus firing off, or an extra pathway causing SVT. Then they use radio frequency energy, basically heat, to precisely destroy that tiny area of problematic tissue.
So it eliminates the source of the dysrhythmia.
Exactly. It's a non-pharmacologic, often curative treatment for many tachydysrhythmias like SVT, atrial flutter, sometimes AFib, or even VT in certain cases.
A deeper look syncope.
Okay, last piece here. Let's connect all this back to a really common and often scary symptom that frequently brings patients in: syncope, fainting.
Yeah, syncope. That's just a brief loss of consciousness combined with losing postural tone, basically passing out. It can have lots of causes, but a big category is cardiovascular. And often underlying dysrhythmias are the culprit. Both tachycardias that are too fast, reducing filling time, or bradycardias that are too slow, reducing output.
So if someone faints, think heart rhythm.
It should definitely be high on your list of possibilities to rule out. But there are non-cardiovascular causes too: stress, low blood sugar, stroke, dehydration. What's really interesting, though, is a common cardiovascular cause called cardioneurogenic syncope. You might also hear it called vasovagal syncope.
The common faint.
Kind of, yeah. But there's a specific mechanism, sort of a paradoxical response. When someone's upright, blood pools in the legs. Normally, the body compensates. But in vasovagal syncope, the brain gets a mixed signal, and it actually reduces sympathetic stimulation and increases parasympathetic vagal tone. This leads to both a sudden drop in heart rate, bradycardia, and blood pressure, vasodilation, hypotension.
So the brain basically hits the brakes too hard.
In a way, yes. That sudden drop in both rate and pressure reduces blood flow to the brain, causing the person to faint, often triggered by things like prolonged standing, heat, intense emotion, or seeing blood.
How do they diagnose that specific type?
If the history isn't clear, a key test is the head-up tilt test. They strap the patient safely to a table, monitor their ECG, blood pressure, and heart rate continuously, and then tilt the table upright for a period, maybe 20 to 60 minutes.
To try and provoke it.
Exactly. A positive test is when tilting reproduces the patient's symptoms, like feeling faint, along with those characteristic abnormal drops in heart rate and/or blood pressure. Other tests might include Holter monitors or event recorders to try and catch a dysrhythmia if that's suspected. Figuring out the cause of syncope is really important for deciding on treatment and understanding the patient's prognosis. Atrial.
Wow. Okay. We've covered a ton of ground today. I mean, from the heart's tiniest electrical sparks all the way up to life-saving shocks and devices, and the critical nursing care that ties it all together.
Yeah, it's a lot, but the main clinical takeaways for you, our dedicated nursing students and colleagues, are really clear, I think. First, a solid working understanding of the heart's conduction system and how to interpret an ECG meticulously. It's just non-negotiable. It's a fundamental nursing skill.
Gotta know the basics.
Gotta know the basics. Second, being able to recognize those critical dysrhythmias, the common ones and the lethal ones, and understanding what they mean for your patient right now. That allows you to intervene promptly and appropriately.
Speed matters.
Especially for the lethal rhythms, right? Like pulseless VT and VF. Immediate, high-quality CPR and getting that defibrillator on fast, that is absolutely paramount. Your speed makes a difference between life and death.
Definitely.
And finally, remember that comprehensive nursing care covers everything from that rapid assessment to precise medication administration to understanding and managing those complex devices like pacemakers and ICDs, and maybe most importantly, providing clear, thorough patient and caregiver education.
So what does this all boil down to for you listening right now?
Our future and current nursing colleagues, it means every single time you glance at an ECG monitor or print out a rhythm strip, you're not just looking at lines on paper. You're looking at a patient's life. You're seeing their physiology in real time. And your informed assessment, your knowledge, your action, it can and does make all the difference. It's truly a privilege and, yeah, a profound responsibility to master this.
Absolutely. Always remember that your critical thinking, your sharp assessment skills, and your ability to connect the dots, connect that ECG strip to how the patient actually looks and feels, and then to the right intervention. Those are your most powerful tools. That link between the electrical activity and the mechanical function, the pump, that's everything in cardiology.
Couldn't agree more. Well, thank you so much for joining us on this deep dive into cardiac dysrhythmias. Keep learning, keep asking questions, and keep making those crucial connections for your patients. We really appreciate you tuning in.
Thanks, everyone.